Welcome, everyone. Very excited to welcome you all today to the second session of Mini Medical School Mind Matters, the Brain and Mental Health. I'm Katie Cullen, and I'm a professor in the Department of Psychiatry and Behavioral Sciences. And I'm also the director of the Division of Child and Adolescent Mental Health. Really excited to have you back for our second session. Our topic today is multifaceted depression and mental health. So what we're going to do is we're going to begin with a moderated discussion, followed by a question and answer session. And so you can submit your questions to our panelists at any time in the Q&A box, which you can find by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will also share the link with you by recording to you by email. So today we have the privilege of speaking with a panel of experts as we embark on a developmental progression of the brain and mental health, exploring conditions such as ADHD, autism, and depression. Before we begin, I'd like to just acknowledge that there is a wide range of terminology that is used to describe these conditions. I want to say that we are committed to using inclusive language that respects neurodivergent experiences. We recognize that some terms we may not align with everyone's personal preferences, and please just know that we're here to foster our understanding, and our hope is to create a welcoming environment for everyone. Okay, and with that, I'd like to introduce our panelists. I'd like to first bring in Dr. Jed Elison. Dr. Elison is the Irving B. Harris Professor in Child Development, Institute of Child Development. His research examines basic developmental processes that contribute to individual differences in social communication during the infant and toddler period. Much of his work to date has focused on the identification of risk factors that differentiate infants who later develop autism from other infants. Dr. Elison, could you please discuss autism in early childhood?
Happy to, Katie. But let me first say thanks to the organizing committee, and really it's a privilege to be here and to share some information about autism. I actually wanted to just follow Katie's cue. I am going to be using both identity first and person first reflections or descriptions of autism. There are, as I'll get to in a few minutes, there are a number of different perspectives and contingencies that have different preferences, and so you will hear me go back and forth between identity first and person first constructions. I wanted to, before jumping into kind of autism in early childhood, I wanted to spend a couple of minutes just giving a bit of a background so that we're all kind of on have some common ground in how we're approaching this. And so the introduction of the term autism was first mentioned by a Swiss psychiatrist named Eugen Bleuler when describing characteristics of thought patterns and cognition in individuals with schizophrenia or psychosis. And he borrowed this term from the Greek autos, or which means self. And it was this idea of kind of this autistic withdrawal of a patient into fantasies, which it was hard to pull them away from these patients. But really, where autism research really became kind of a phenomenon that people began to study in earnest was after a publication in 1943 by Leo Kanner, in which he described a case series of kids that he saw in his clinic at Johns Hopkins. And we considered Leo Kanner kind of the father or grandfather of autism. And he was not only his really keen clinical observations that helped to distinguish this neurodevelopmental disorder, but he also, so he wasn't only identifying symptoms or profiles of impairment, but he was also identifying strengths in these kids who at the time were, primarily considered feeble-minded, or what we would refer to now as having an intellectual disability. Case number one in Connor's case series is referred to as Donald T. I mentioned this simply to point you to a reference. There was a really terrific PBS film that debuted last year called In a Different Key, and it was produced and directed by John Donvan and Karen Zucker, in which they get to know Donald Triplett, and they go to his hometown and they showcase how the community really rallied around Don and stepped up to accommodate his disorder and his personality. And it's definitely worth your time if you're interested. Autism is a heterogeneous, I want to introduce one kind of jargony term, and that's heterogeneity. We talk about etiological heterogeneity, and that simply refers to variability in the cause of autism. And we also talk about phenotypic heterogeneity, and these are really important concepts. Phenotypic heterogeneity is, again, just jargon for variability in how the disorder manifests. Okay, and we, built into the name or the label is autism spectrum. We see variability in symptom manifestation that spans from individuals who are minimally verbal, who have very few spoken words, to those who may have a verbal IQ of 140. Just as an example of the kind of variability that we might see. There are two symptom domains that are defining features of autism. One is social communication, and the second is restricted and repetitive patterns of behavior. And within each of these domains, there are multiple specific features that clinicians are going to be looking for. In order to receive a diagnosis, these symptoms should appear early in childhood, and they should exert some degree of clinical impairment, which makes it challenging for the individuals. Now, beyond these two symptom domains, there is a host of co-occurring features that may ride along with an autism diagnosis. From cognitive co-occurring features, so language delay is not uncommon in young children. And one statistic that has kind of stood the test of time is the prevalence of co-occurring intellectual disability, which occurs in around 30% of all individuals diagnosed with autism. There are medical comorbidities as well, gastrointestinal features, sleep disturbances, seizure disorders. Seizure disorder plays a really kind of another kind of central theme in the history of autism. It was the identification of a co-occurring seizure disorders has helped kind of identify and reposition autism as a disorder of brain development. In addition to these, what I've already mentioned, we also see co-occurring psychiatric features, including co-occurring anxiety disorders and major depressive disorder, which have been estimated to occur to present in about 25 to 35% of all autism cases. And which typically have their manifestation later in childhood or early adolescence. With regard to early development, historically, autism in DSM-4, in the kind of the manual that preceded DSM-5, there was a requirement that the symptoms must emerge and manifest before the age of 3. In DSM-5, it changed to early childhood. And we do know that there is some variability in the timing by which these symptoms that define autism manifest. Variability in the timing of the consolidation of the symptom profile. But what we know is that the average age of diagnosis in the United States is around 5 years of age, between 4 and 5. The best kind of that said, the American Academy of Pediatrics made a recommendation in 2006 that for universal autism screening at 18 months and 24 months of age. Our screening instruments, there's room for improvement in our screening instruments. But that said, we often see consolidation of the symptom profile between 18 and 36 months of age. There are a few cases, examples in the literature where we've seen younger diagnoses, but typically the earliest that we might diagnose is between 18 and 36 months of age. Now, a lot of the work that has yielded kind of really new information about the early development in autism has come from a research strategy in which we're leveraging what we know about the genetic heritability of autism. And in about 20 years ago, researchers started studying younger siblings of autistic children with the intent of following these children as they grow up and doing assessments along the way, surveillance, with the acknowledgement that a greater proportion of those infants will go on to develop autism than in the general population. So it was a research strategy for us to really hone in on the early developmental features of autism. And I've been working on a project that has been following infant siblings since 2007. We've had multiple cohorts of infants enroll, and we launched the study last year where we're studying these children as they age into adolescence. And so it'll be a kind of a one-of-a-kind study in which we're tracking brain and behavioral development from as early as 6 months of age until through adolescence. Now, what have we learned from these infant sibling studies? One thing that we've learned is that the best clinicians in the world cannot differentiate a 6-month-old who goes on to develop autism from a 6-month-old who doesn't. Okay. What we observe is the emergence of a series of features that do manifest at 12 months of age. The earliest overt or observable features that differentiate kids who go on to develop autism from those who don't have been identified at about 9 months of age. Two of those features include lack of or inconsistent responding to one's name, and less responding to joint attention. When a parent makes a bid for an infant's joint attention, does the child follow? So those two features have shown promise for very early markers of the disorder. But even that, with these features appearing at 9 months or 12 months, they're really differentiating groups of kids who go on to develop autism from those who don't. There still there are not clinical recommendations, and our clinicians still aren't able to diagnose autism as early as 12 months. But as we're beginning to see these features emerge, that has led to a number of questions about whether we can leverage technology to identify changes in brain structure or brain function prior to the manifestation of these early emerging symptoms. And so that's another area of research that I've been active in for the last 15 years. And we've had a kind of a big paper in 2017, a couple of big papers where we were able to leverage neuroimaging data at 6 and 12 months of age to predict which infants will go on to develop autism with a high degree of accuracy. These findings warrant replication, and we're currently collecting a new cohort of infants to see if we can replicate some of these findings. With the intention here is that if we can identify a predictive biomarker with sufficient sensitivity and specificity that we may be able to implement some pre-symptomatic interventions that may attenuate or mitigate symptom expression or development. I thought I would include a little bit of information about what we know about brain development. I think of the history of brain imaging in the autism field as kind of a history to some extent of hubris with some periods of insight and ingenuity and innovation. I think that in the early days, there was a lot of consensus and hope that we would identify, a single brain mechanism that could explain the heterogeneity that we observe in autism. But I think what we're finding, what we've learned in the last 30 years plus of neuroimaging is that there isn't something analogous to like a lesion that would explain the autistic profile. But instead, what has shown promise is actually taking a distributed network or brain approach. And in fact, I think it was somewhat innovative when in 1997, one of these researchers who's played a central role in thinking about brain development and autism kind of speculated that the primary defect in autism is the result of abnormal development of a distributed neural network involving a number of brain regions. And at the time, that was a different way of thinking. People were hoping that we could identify abnormalities in the cerebellum or abnormalities in the hippocampus or abnormalities in the amygdala that might prove to be kind of a diagnostic biomarker of autism. But that simply hasn't borne out. So the best approaches, I think, contemporary approaches to thinking about brain-based biomarkers is tackling this problem from really thinking about structural connectivity across the whole brain and functional connectivity across the whole brain. Some of you may have attended last week's session and learned about structural and functional connectivity. So I think that's where we are now as a field is really thinking about kind of these broader networks. But there's also another piece that's become really central to the research efforts in thinking about either predictive biomarkers or diagnostic biomarkers. And that's in better characterization of the phenotype of the strengths and areas for growth that we observe in the cases with autism. And there's a strong trend, a growing consensus in the field that if we can get research samples that are large enough, we might be able to parse some of that heterogeneity in the phenotype, identify sub-profiles or subgroups of kids, of autistic individuals that we may be able to identify more homogeneous profiles that may lend themselves better to understanding or characterization of more specific brain characteristics or brain phenotypes that explain the behaviors in a more specific way. Lastly, I want to highlight that autism is it's a very complicated field and complicated phenomenon, and there are multiple contingencies and perspectives, and you get different answers if you go to a physical therapist or an occupational therapist or a psychiatrist. Unfortunately, and former NIMH director Tom Insel talked about the 4 kingdoms of autism, where you might get different understanding about the disorder from these 4 different groups. And I think what he advocated was that we needed to do more to cross over, to integrate these perspectives. And these 4 kingdoms can be thought of as one that I've been describing to you is a group of people who think of autism as an illness. And that's beginning kind of in the medical model. This is something that we're seeing this is a neurodevelopmental disorder that we want to develop interventions and help these and provide supports for kids and their families. There's another kingdom that's defined as illness, and this was kind of highlighted by the early and sustaining anti-vaccine movement, where there was a group of parents who tried to explain a regression in their kids' behavior and a subsequent autism diagnosis as it's kind of coincidental timing with vaccine schedule. But this is the thinking about autism as an illness is extended, and I think that there's evidence to suggest that anti-seizure medication taken during pregnancy, certain types of anti-seizure medication during pregnancy may increase the risk for autism. So this is another kind of thinking about a teratogen that may increase the likelihood of autism. The other two kingdoms are perspectives or contingencies are represented by insight is another, and you do encounter individuals who are studying autism to try to help try to simply understand aspects of the social brain and trying to understand how the brain works, and how all of these neurons and cell ensembles and networks give rise to complex social communicative behavior. And the final group is the final kind of perspective or contingency is one of identity. And these are primarily individuals who are self-advocates, operating from more of a social model of disability where we're celebrating the diversity of individuals, and we shouldn't be trying to treat or cure individuals, but we should be working hard to create supportive environments for people of all abilities. And I think that Tom Insel was onto something when he said, we need to figure out ways to come together, and for each of these contingencies or perspectives to communicate with one another. And I find myself thinking a lot about the social model of disability. Much of my work operates in more of a medical model, but I interface regularly with people who operate under these different perspectives. So hopefully that gives a little bit of insight into how I'm thinking about autism and early childhood.
Wonderful. Thank you so much, Jed. And that was just really great overview and also really insightful. So there will be time for questions after the three talks, but for now, I'm going to bring in and introduce Dr. Lidia Zylowska. Dr. Zylowska is an associate professor in the Department of Psychiatry and Behavioral Sciences in the medical school. She pioneered the application of mindfulness in ADHD and co-developed mindful awareness practices. Dr. Zylowska directs the Adult ADHD Clinic and leads the Integrative Psychiatry and Wellness Program. She is an author of an award-winning book called The Mindfulness Prescription for Adult ADHD, an 8-step program for strengthening attention, managing emotions, and achieving your goals. And she's also written a second book called Mindfulness of Adult ADHD, a Clinician's Guide. So Lidia, can you please speak to us about adult ADHD and mindfulness?
Yes, thank you, Katie, for the introduction. I'm going to share my slides, so just bear with me for a moment. Okay, so I have slides, and I hope for those that visual information is helpful, that will be a friendly way to look at the information. Just a quick disclosure here. And first, I want to talk a little bit about ADHD across lifespan. Sometimes we think of ADHD as a disorder of childhood, as it is a condition that is diagnosed often in childhood. It's a neurodevelopmental condition, but more and more we recognize that this is often a lifetime condition that affects many adults. The rates of diagnosis have been increasing over the last decade. I have here 8 to 10% of children and 4% of adults in the US having the diagnosis. The latest numbers actually that just came out recently are 11% of children in the US having the diagnosis. Many of the children, majority of them, 60% or more, continue to have the diagnosis as adults. And over the last, several years, over the last decade, and particularly since the pandemic, we've had increasing diagnoses in adults, particularly women, who traditionally are not picked up as children as frequently as boys. And we see a lot more women being diagnosed later in life. Here, just want to highlight how, what are the things that we look at when we're diagnosing ADHD. So in the, if you can just look at the blue squares, there are the 2 buckets of symptoms that we typically think of when diagnosing ADHD. One bucket has to do with inattention, focus issues, disorganization, and the other bucket of symptoms has to do with hyperactivity, impulsivity. And those that have ADHD may have challenges with inattention, disorganization alone, or may have also issues with hyperactivity, impulsivity. Majority of people actually have symptoms in both of those buckets. Some individuals may mainly present with hyperactivity and impulsivity. But what this slide is trying to also show that there are many different ways we understand ADHD. There's a lot of other things that travel with ADHD. In fact, in adults, oftentimes we don't see ADHD alone. We see lots of other things that are maybe challenging. The helpful way of thinking about ADHD is not that it's attention deficit, but it's attention regulation difference. Perhaps example of neurodiversity of how the brain has developed. And that difference in regulating attention also is found in how emotions are regulated and then also behavior. So when working with ADHD individuals, it's often helpful to not just focus on those classic symptoms of ADHD, of inattention and hyperactivity, but also see what else they're struggling. We know impulsive emotions can be a challenge. Worry and overwhelm is a frequent companion of ADHD in adulthood. Increased stress, that also goes for families affected by ADHD. And very often there is another comorbid mental health condition. Anxiety, very common. 50% of adults with ADHD having also anxiety disorder. Depression is very common. Substance use disorders may be common, and other conditions as well. We also see that the self-concept can be affected. We see lower rates of self-esteem in children and adults with ADHD. There's recent research looking at self-compassion ability being lower with adults with ADHD. And so that's one aspect that I think it's important to look at, and I'll touch on that when talking about mindfulness. And in addition, ADHD can interplay with physical illness. Some comorbid physical illnesses are more common when somebody has ADHD, such as obesity, asthma, other issues. And now we're learning also about the effects of hormonal shifts for women in how their ADHD is manifesting. So this is all to say that ADHD can very much affect the whole person, really the whole life, and in fact, whole family, knowing that there are, we do understand there's genetic predisposition to ADHD. So parents with ADHD are more likely to have children with ADHD. And in my work with adults, I often see adults coming first to diagnosis because their children were diagnosed, and no one has really recognized the adult's ADHD until as a parent, they recognize themselves and their children. Here, we talk about all these difficulties that come with ADHD, but I think it's important to also acknowledge that many adults with ADHD, some of them well known, like here, Olympic medalist Simone Biles, have been very vocal about having the condition, and some people even credit their persistence or some unique abilities to having kind of a different way of approaching things, a different way their brain works. And so, especially when supported, those with ADHD can be quite successful. So what are the treatments that we use? The most evidence-based treatments are medications, stimulants, as well as non-stimulant medications. So examples of that would be methylphenidate or amphetamine type stimulants. People may be familiar with the brand names like Adderall or Ritalin, as well as cognitive behavioral therapy. Those can be tremendously effective and oftentimes really turn someone's life around, but they also have significant limitations. Not everyone benefits from medications or can tolerate them. About 30% of adults can't. We also know that even if somebody benefits from medication or cognitive behavioral therapy or both, there are still remaining difficulties, the ones that I've mentioned, how perhaps they're relating to themselves, their self-concept. There may be other difficulties with emotional functioning. So we are constantly looking for what else can be helpful with ADHD. And generally, we understand that multimodal or multifaceted approach is needed for most people to support them. And I've listed some of the things that are used in a clinical space for ADHD, and I'll focus on the mindfulness-based training approach. So what is mindfulness or mindful awareness? This is an approach that's based in meditation training derived from Eastern meditative traditions that has been popularized in the US by Dr. John Kabat-Zinn, who developed a model called mindfulness-based stress reduction, or MBSR. And he defines it as paying attention in a particular way on purpose in the present moment and non-judgmentally. And it's a really great definition that gets at the heart of two steps that happen when we engage in mindfulness. So when we engage in mindfulness in meditation, or perhaps even through brief shifts in daily life, you are engaging attention and purposefully moving it towards something in the present moment. And you're also shifting and engaging your attitude. And what's important here is that we're practicing approaching our experience in the present moment with non-judgment, curiosity, openness, and acceptance. So it's trying to be less reactive and more of a witness of what's happening in the present moment. It might be helpful to just contrast what is not mindfulness. Mindfulness can happen spontaneously, but more often than not, spontaneously, what we are doing in the course of our day is not to be mindful and aware of the present moment. We're often are shifting into thinking, doing, planning, remembering, so very much caught in our thoughts. So this picture shows, a person being, their attention being pulled in lots of different things in their thinking cloud. You can think of it, this in many ways could represent what those with ADHD experience, that they have lots of thoughts and their attention is up here. And mind wandering, for example, or being distracted or scattered is a common experience. This can also happen across other conditions, anxiety, depression. We also know that rumination, being caught in thinking, often very difficult thinking, is an issue. And in fact, mindfulness is being brought to different conditions in the mental health space, and showing effects in depression, anxiety, substance use, as well as ADHD. I mentioned mindfulness is a practice, is a meditation practice, and we often refer to that as formal practice of either sitting or walking mindfulness. But it's also something that can be practiced informally in daily activities. Those practices can be very short. And in fact, there may be some things that a person is already doing that you could bring mindfulness to. And some contexts may induce or help support mindfulness, like being in nature, for example. So the idea is that the more you engage in these shifts of attention and attitude, engaging in the mindfulness process, you will develop more of this as an enduring ability or mindfulness trait. So what happens when somebody engages in mindfulness? Sometimes it might not be intuitive that mindfulness and ADHD intermixed well. And when I was starting this work initially, over 10 years ago, this was questioned. Is mindfulness a good approach to ADHD? What is it doing? How is it helping? So on one level, we are engaging attention when we practice mindfulness. And this is kind of a graphic of what you would do if you focus on your breath. Very common practice. So typically you would focus on the breath, and many of you who have tried to meditate through mindfulness or other means, you often lose your focus. Then you become, you lose your focus because you start thinking about something. There may be some distraction going on. Once you become aware of that distraction, you have the opportunity to then refocus on the breath. And then the cycle repeats. You focus on the breath for a little bit. Typically, you get distracted again. So in these moments of awareness of distracted focus, you have the ability to redirect. And with that, you're strengthening you're engaging your focus attention, you're strengthening your ability for that. You're also engaging open attention or kind of monitoring attention. Because much of mindfulness practice is focused on internal experiences, we also are engaging interoceptive or, focus on body sensation attention. The practice is thought to, especially through that shift in attitude, is to promote more accepting, compassionate responding, overall being less reactive to your own experience, and through that developing meta-awareness of your experience and self-regulation. Oops. So I'm trying to move this slide. Here we go. So I want to just overview how do we train mindfulness in ADHD, and what kind of research we have available. In the mental health space, mindfulness has been brought by looking at the model of MBSR, or mindfulness-based stress reduction program, and adapting it to preventing relapse into depression. And that was done by developing mindfulness-based cognitive therapy, or MBCT training. And those two models are group training models, typically done over 8 weeks. They have become the main models in which the work in ADHD has happened. Myself and colleagues at UCLA have looked at MBCT and adapted it to ADHD, developed a program called Mindful Awareness Practices, MAPS, with the idea of making it user-friendly for someone who may have trouble with attention or have trouble with restlessness. Others, particularly in Europe, have used adapted MBCT for ADHD adults. And there's some work done in Netherlands using combined training for parents and children, a program called My Mind, and some work in China looking particularly on parent training and having effects on the children. There's also other models that are well known in mental health space, such as DBT or acceptance commitment therapy, that also have some research in applying it to adults with ADHD with positive effects. So I want to just tell you a little bit more about the MAPS for ADHD that we developed, how it's organized, and kind of the intention behind it. So it is an 8-week program, and certainly it can be done at a pace that's needed for a person when it's done in an individual training model. And the intention of the first session, the first 3 sessions, is to start observing that tendency to be distracted. Start paying attention to attention, its moves, its behavior, as you will, and bringing it to predetermined anchor in the present moment. So the practices are looking at, are emphasizing anchors such as senses, the breath, and the body as these anchors to the present moment that you can bring yourself back when you notice yourself distracted. The later sessions are about bringing now this ability to monitor your attention and direct your attention to be more observant of your inner experiences and deepening awareness of thoughts and feelings, reactions, maybe behavioral patterns, and learning to choose a response, so training self-regulation. Here are some themes of how this was adapted to ADHD. We wanted to bring education about ADHD, very much in the spirit of talking about neurodiversity and how symptoms can exist on the spectrum, thinking of ADHD both as a difference as well as disorder when there is struggle and impairment. The meditation practices are very gradual, starting with 5 minutes, increasing at individual pace up to 15 minutes, and emphasizing other options, not just sitting meditation that may be difficult for some people. So having options like mindful movement and informal practice. We also thought it was very important to bring appreciation exercises and loving kindness as part of this training, knowing those deficits or those difficulties with self-concept, and bringing some ways to make it user-friendly, like to those who may trouble engaging in any sort of skill training. So having reminders, having a partner to do mindfulness training, and looking at bringing curiosity as you're learning the mindfulness practice. What are you noticing about the ADHD in daily moments? How you relating to yourself? Even how is medication affecting you? Here's a quick overview of what we have in terms of research up to date. It's still a fairly new area of intervention research. The initial studies, including my own, were really a feasibility study looking at modification of the training and application to ADHD for both for adults and teenagers. And then more recent studies have incorporated control groups, waitlist control being the most common, and then most recently more active controls of psychoeducation. Overall, when you look at what we have available, these are the effect sizes of this intervention. Typically, we see larger effect sizes on inattention or hyperactivity in adult samples, a little bit less in child adolescent samples. And those are, remarkable findings, but keep in mind, because many of them don't have the control, these are likely to be lower when you have a control. And in fact, the couple newer studies comparing mindfulness to psychoeducation have been interesting, because both interventions were similarly effective, and I'll comment on that in a moment. A lot of the discussion in the space of mindfulness and ADHD has been trying to hypothesize what mechanisms may be active in the training mindfulness, what might be happening as the symptoms are improving. There is literature from mindfulness outside of ADHD research showing that areas of the brain that are involved in attention regulation, emotion regulation, self-awareness, executive networks is engaged by this practice. And those overlap with the brain regions that we know are important in ADHD and different in ADHD. The other area of interest is looking at the relationship between mind wandering, ADHD, and mindfulness training, thinking that mindfulness is modifying the tendency to mind wandering, modifying the network that's involved in that, the default mode network, and that that may be the critical mechanism here. There was one study that came out just 4 months ago, in fact, looking at this interface of mind wandering, ADHD, and mindfulness, finding that those with decreased mindfulness ability had more mind wandering, and that was showing up for having more comorbidity if you had ADHD, so more tendency for anxiety and depression. So interesting finding that needs more follow-up, but that may be one way mindfulness interfaces. When it comes to what we know already, besides sort of the suggestive research from different areas of mindfulness research, we still don't have a lot of studies with mindfulness and neuroimaging. We have one that has looked at MAPS training versus psychoeducation, and looked at improved symptoms and performance on working memory tasks, which are cognitive tasks, often impaired in ADHD. And both interventions improved symptom equally. There was also finding that on the brain level, there was more activation in the circuits of interest involving working memory and attention in the MAPS group as opposed to psychoeducation. But it was remarkable that both of the interventions were equally helpful. So what that tells me is that psychoeducation is a very helpful intervention in ADHD, and that increasing awareness through education or through experiential practice has significant effects for those with ADHD, for self-understanding and for actually mitigating some of the symptoms. So just a wrap up to say that this is an area of a lot of interest to do more studies, and particularly to do longer follow-ups, looking at some subgroup effects. How do patients who take medications do with this training, and how about not being on medications? We don't have those answers yet. Would psychoeducation be better upfront and then followed with mindfulness, or vice versa? So some sequencing questions as well. Here, I want to just end for those who are interested in exploring this area, some of the resources that I and colleagues created for patients and for clinicians, as well as a number of free resources on the right side of the slide of how to engage with mindfulness in an ADHD friendly way. One of the resources is the Attention Deficit Disorder Association, a nonprofit that works with or really caters to adults with ADHD. They have a peer mindfulness group, and that's one way for people to try and kind of learn from their peers. And here's some resources for those that are interested in resources or on mindfulness for children, adolescents, or parents. With that, I just wanted to acknowledge the funding that supported the initial work, and others, my collaborator, Dr. John Mitchell from Duke University, and of course, individuals with ADHD who are curious to engage in this approach. And with that, I'll wrap it up.
Wonderful. Thank you so much, Lydia. That was really, really fantastic and so informative. Thank you for sharing that with our audience and with me. Last but not least, it's my great pleasure to introduce Dr. Sofia Vinogradov. Dr. Vinogradov is our department chair in the Department of Psychiatry and Behavioral Sciences. And here at the medical school, she's also the Donald W. Hastings Endowed Chair in Psychiatry. Dr. Vinogradov directs a translational clinic neuroscience laboratory that focuses on cognitive dysfunction in psychotic disorders. She studies the neuroplastic effects of cognitive training and on the brain with the goal of understanding how the brain system functioning, how to change brain system functioning and how to promote recovery. Her work has contributed to a growing interest in the use of computerized brain training to treat brain information processing abnormalities. So, Sophia, could you please talk about your research on psychosis and retraining the brain, but could you also please speak more broadly about other disorders such as depression for our audience?
Thanks, Katie. So, I'm going to shift emphasis a tiny bit from Katie's question. And I'm also going to shift emphasis a bit from my two wonderful colleagues who really have shown you, the depth of the scholarship that they bring to their work. And I'm going to bring things to a different level of dialogue here. I was looking through some of the questions that are showing up in the Q&A, and I want to be responsive to kind of sort of some of the general themes that I'm seeing in the questions, and also to perhaps be a little bit less academic and scholarly and a little bit more kind of practical and how should I say, real world, right? Because we are talking about things, whether it's autism spectrum experiences or ADHD, we're talking about things that real people in the real world are experiencing. Some of you are experiencing it, or you have loved ones who are experiencing it. And you're wondering, how do I understand these things, these experiences more deeply? How do I feel hopeful about new approaches we can take? And I'm going to pivot a little bit away from my own particular area of research. I focus on a pretty serious set of mental illnesses that we call psychosis spectrum illnesses, such as schizophrenia. And I'm going to focus on something a little bit more common, because I think by focusing on this more common set of experiences, which I'm going to term depression, particularly major depression, I'm going to be able to tie together some of the themes that I see coming up in the questions, and then also give some hopefully pragmatic perspectives for all of us, because one of the things we know about depression is that it is increasing in society. We're seeing higher and higher rates of depression, and we are particularly seeing higher and higher rates of depression in young people, in children and adolescents, and that is troubling. And I suspect we're all troubled about that. But let me back up a moment to some of these themes that I've been seeing in the questions. And I love that they're there, because they are really all about what makes psychiatry so exciting and in some ways so complex. And you heard a little bit of it from my two colleagues. And this is the theme of things that seem to happen together. So autism spectrum functioning along with ADHD, along with depression, ADHD along with depression, depression along with features of autism. Why is it that we see these co-occurrences all the time? And the reason we see them all the time goes back to some of the comments that Jed, the Dr. Elison, was making. And it's a little bit hidden in some of what Lydia, Dr. Zalewska, was showing you, which is the brain is complicated. The brain is very complicated. And the brain is not like, you've got a gasket here and you've got a piston here. And if this one fails, you get ADHD. And if this one fails, you get autism. It's not at all like that. And if this one, this cog in the wheel, in the machine fails, you get depression. That's not how the brain operates. Jed made reference to this idea of networks. I like to sometimes use the term wiring diagram. The brain is an information processing machine. It's an information processing organ. Its job is to take in information from the outside world and from your inside world and put it together and help you figure out what you're going to do next. And if some piece of the wiring diagram of that information processing machine is off a little bit, or several pieces are off in different ways, then guess what? It might make the brain a little bit more have struggles with certain kinds of attentional tasks, or it might make it might build a brain that really has difficulty processing and responding to socially relevant information or problem solving. And I think you probably understand this analogy I'm creating for you of this wiring diagram, this complicated wiring diagram, and all you need is for several wires that cross and interact, and connections that cross and interact to be a little bit off kilter, and you can see how you start to create like all these different variations. And you can get perhaps a system that is a little bit off, that's interacting with another system. And now you've got both attention deficit disorder, and you've got some autism spectrum features. So another analogy I like to use, it's not a great analogy, but again, it might help you think about the complexity of what the brain is having to do and how all these different systems have to interact, is like a symphony orchestra, right? You have to have a string system, and you have to have a percussion, and you have the wind instruments, and all of these, right, have to sort of be operating perfectly well as a separate section. The strings have to be in tune, and you've got to have the wind instruments in tune. You have percussion on the right beat, and yet each of them can also be off a little bit, and depending on how they're off a little bit, you get these sort of different combinations of problems in terms of your symphony orchestra. Depression now is very similar. But has some other aspects to it that I just want to highlight, and a little bit different from the two syndromes we've been talking about. Depression is about mood. And you think, okay, mood, what does mood have to do with information processing? Well, the fact of the matter is it can sometimes have a lot to do with information processing, because one of the things we see that when people are getting depression or are prone to depression is their brain has become especially attuned to information in the environment which is depressing. So the brains of depressed people will tend to focus on negative things in their environment. And it can be super simple stuff like a negative facial expression, a negative interaction they have with someone, and it gets over processed by the brain. Too much resources are being allocated to it. And that starts to shift, again, the entire mood state, the entire body state of the individual. The other interesting thing about depression, and quite honestly, it interacts with these other two syndromes we've been talking about, is that depression's very tied into anxiety and to stress responses in the brain and in the body. So if you stress someone enough, we know even in animal models, if you stress an animal enough, you will start to create aspects of a depressive syndrome. If you create too many triggers for anxiety and uncertainty in an environment, you will create the state for depression to emerge. Depression in humans is very tied into our stress response system. Well, guess what? If you have ADHD, you're stressed and anxious a lot of the time, and that may make you more prone to depression. If you have autism spectrum symptoms and you're struggling to cope and interact with the environment and feel that you're able to do that adaptively and get your needs met, and it's a struggle, that's going to cause, again, some of this stress response in your body, stress hormones building up, and that can, again, sort of lead over and cascade into depression. So I hope through this rather, kind of hand wave, I can see myself hand waving on Zoom, this kind of hand waving explanation, you're starting to see how there is almost never in psychiatry these clear delineations between these categories of syndromes. They are always interweaving with one another. The other, kind of stating the obvious comment that I want to make about depression is, and about this idea of stress and uncertainty and anxiety, what happened in 2020 and 21, and even into 22, we were submitted at a population level to really the kinds of stress and uncertainty we had not experienced before. Most of us have not experienced before. And guess what? We saw rates of depression increase, as I'm sure you've all heard about. We saw them increase in adults, and it is now estimated that at this point in time, roughly 20%, kind of on average, 20% of adults will experience depression at some point. In youth, that number may be even a little bit higher. And we're certainly seeing the rates increase in youth. Again, a sort of troubling phenomenon. By the way, just for this presentation, I was looking up to see, the variation in rates of depression across different states in the country. And I don't know if I'm happy to report, or at least, we can think about it, that Minnesota sort of sits squarely in the middle. So we have ranging at one end rates of about 14% or so, and that's in I believe that was in California. And then the other end of the extreme, we have rates of about 26%, and that was in West Virginia. And then Minnesota's right in the middle at 20% at any given point in time. So maybe we've got some work to do. You might say, why West Virginia? Well, this is another aspect of depression I really want to highlight, because I think it has, again, societal implications. We know depression shows up when individuals are not physically well. So in West Virginia, which has very high number of sort of health disparities and poor health issues for a number of reasons, high rates of smoking, high rates of cardiovascular disease, high rates of obesity. We know that when those kinds of physical medical illnesses are present, we see rates of depression go up. And so this is pointing out another kind of interesting thing, I would say, about psychiatric illnesses generally, but particularly with respect to depression, which is depression is very intimately tied to our physical well-being as well. We see depression happening after certain infectious illness, as an example. It's also probably related to the fact, which is something which is sort of common lore, and there's been some research done in this area, but it's not the great research, which is people's can treat their depression, and we can see moods improve when people improve their physical health. Whether it's tackling their diabetes, tackling obesity, improving their cardiovascular fitness. But even when we see people who have not been exercising sufficiently take up good aerobic exercise regimens, we can see depression lift. In fact, one of the best treatments for depression is indeed regular exercise. So again, pointing out to the complexity of how our wonderful brains are interacting and picking up signals from our bodies and from the state of our bodies, and that is actually influencing how our brains work as well. I want to say just a little bit about kind of treatment of depression. Well, one other point to make, perhaps, that this is just to talk about, well, why are the rates of depression increasing? Well, we certainly know that the pandemic played a role. Substance use, higher rates of substance use, which also went up during the pandemic, that will play a role in contributing to depression for the reasons I was just describing to you. There may also be other reasons. I was talking about the importance of exercise. Well, conversely, we as a society are physically less and less active each decade. It's kind of amazing when you look at the last 30 years and you look at the data, how much less active we are physically than we were before. That may be contributing. Dietary factors may be contributing as well. And then, of course, kind of the digital world. There's been a lot of interesting research emerging, particularly for youth. And some of you may have heard about it. It's been in the popular press, which is the world of social media and the continuous flooding of digital information that can promote anxiety and feelings of inadequacy, feelings of not measuring out, feelings of missing out, particularly in vulnerable, kind of preteens and early teens and teenagers, is likely also contributing to these increasing rates of anxiety and depression. So there's a lot of factors that are going on right now. Depression, particularly as a serious syndrome, does have some heritability to it. About 50% of it seems to be attributable to genetic factors. So if there's a family history, that already puts one at risk. But 50% is not. So again, 50% is going to be due to some of these environmental factors, stress that I've mentioned to you. And then finally, an environmental component that I haven't yet just directly mentioned, but I think you've probably already been thinking about it because it goes along with stress, is trauma. So exposure to psychological trauma, to abuse, to deprivation, to repeated social injustices, That is causing, again, that stress cycle that we know is highly contributing to onset of depression. So that's a little bit about how to think of it as a syndrome. The great thing in some ways about discussing depression is that we kind of all know what I'm talking about, right? The change in mood, where your mood goes low, is something that every human being has experienced. The difference about when it becomes depression is that it goes low and it stays low and there's no variability. And in fact, there are some people who would describe it, who particularly with chronic depression, who would say, well, it's not even, I wouldn't even call it anymore that it's going low. It's just kind of like stuck. And there's like this continuous blah feeling. It's not sadness per se. It's not like grief. It's not like I'm aching for something. It's just this kind of flat line. Whereas when someone isn't having a major depression, there's much more variability. We have good moments, we have bad moments, and so forth. So this raises, is that if I've talked about all these other factors, right, that are contributing and that can help be part of the causal factors for depression. So then the question becomes, well, what do you do about it? And again, I hope you've been sort of beginning to think about the message that what you can do about it is a number of things, right? And as I said, exercise is a wonderful approach. Mindfulness that Lydia was describing to you can be a wonderful approach to depression, particularly the forms of depression that are not too severe, because what you start to learn to pay attention to is when does your mood tend to go down and stay down? What are the sorts of things that you tend to ruminate about? I was talking about how brains with depression tend to be a little bit stuck on negative information in the environment. You start to watch that in yourself when you start to use compassion and so forth. Speaking of mindful, I'm mindful of the time here, so I want to conclude by just saying a few comments about treatments. There was a question in the Q&A about the use of ketamine. So I'm just going to briefly describe the treatments we have. We have medications that we can give for depression. They have pros and cons, like all medications do. They're useful probably in about 50, sometimes 60% of people. And there's a number of different medications one can try. When medications fail, we have other kinds of treatments. We have treatments that include ketamine, IV ketamine, given in some repeated doses. That's for treatment-resistant depression. It can be kind of a miracle when it works, and it works for about 50 to 60% of people. There was a question as to whether it lasts. There's not been a ton of research done on it, but it certainly seems that after the series of ketamine treatments have ended, there is a subgroup of people who will relapse, a small subgroup once the series of ketamine ends, but there is a larger subgroup of people that will continue to show a response, up to about 1 year later. But clearly we need more knowledge in that area. There is some work being done now, of course, with the use of psychedelics, such as psilocybin in the treatment of depression, particularly when there's a trauma history of depression, and it has to be combined with a really kind of a guided psychotherapeutic experience as the person processes the trauma. There's neuromodulation, which is where we use different kinds of electrical stimulation on the surface of the brain. It can be a magnetic form of stimulation, which induces some electricity. There's some studies of actually very mild electrical currents as well. And we can target certain areas of the brain, which we believe play a role in modulating mood, and we see some positive responses there. Again, those tend to be reserved for people who've got depressions which are more severe. And then finally, though it has a kind of a very bad rap in the general public mind, we know that there's a very effective treatment for very severe treatment refractory depressions, which is called electroconvulsive therapy, which is where the individual receives some anesthesia, and then while they're asleep, some electrical current is applied to the surface of their brain, and it induces a small seizure, which in a sense allows the brain to reset itself. And it's highly effective and very quickly effective. So there's my world tour of what we know about depression right now and how we think about it, and in particular about how we think about why something like depression and ADHD and even autism spectrum disorders are often showing up in different combinations in different ways in different individuals. Turn it back over to you, Katie.
Wonderful. Thank you so much. That was really fun to listen to you speaking about depression, Sophia. Thank you. I'm going to bring it back to our first speaker, Jed. Could you please tell us, are sensory issues one of the symptom domains for autism?
Yeah, sensory symptoms were included in the latest version of the DSM. Is under the kind of rubric of restricted and repetitive behaviors. And so yes, they are part of the symptom classification. And I think I would just add that we're learning a lot about sensory function, especially in the last 10 years or so, and trying to understand, not only what might be classified as sensory responsiveness or sensory reactiveness, but trying to understand the physiology behind that as well. And so it's an area of very active research.
Can I just tag on one more question for you, Jed, while we have you have the floor, and that is, has the prevalence of autism increased?
Prevalence estimates that are shared every April, except every other April, I guess, not this year, have been increasing, since around 2001. Now, there were big changes in how we classified autism as early as DSM, as early as 1994. And so we would anticipate some big changes were made to the DSM in 1994, which is the book that we use to define our psychiatric disorders. But it does seem to be increasing. There are lots of reasons that have been kind of batted around as to why that may be the case. I think the best evidence is for increased awareness and something that we call diagnostic substitution. And there's really good evidence for this coming from California, where because of disparities in access to certain types of interventions and services, individuals are replacing the diagnosis with intellectual developmental disability with a diagnosis of autism in order to get the services that they need. So we are seeing aspects like diagnostic or features like diagnostic substitution that may be contributed to increased prevalence, but also we think that greater awareness is one of the most important contributing factors to what appears to be an increase in prevalence.
Very helpful. Lydia, you told us about your mindfulness approaches. Could you speak about mindfulness practices for ADHD in the context of an attention-divided world with social media, internet, et cetera, and the impact on mental health?
Yes, so just as Dr. Vinogradov mentioned, we are now in a very disjointed or distracted world, and there's so many things vying for our attention. And I think anyone can relate to moments when they do feel either distracted or maybe overly focused or hyper focused on whether it's the computer screen or social media. So there are challenges to being present. We have more challenges now in the environment to being either single focused or being focused particularly on the present moment, or even to be more focused on our own experience. So we're in a way more disconnected from ourselves because our attention is pulled externally so much. So it's more challenging to practice mindfulness. And I think certainly it's, if you want to practice mindfulness, it's important to think about the context and maybe setting in which you might practice it formally, or maybe certain activities, as I mentioned, being in nature that may help you with that practice. But, the core of the practice is to be aware where your attention is, where it goes, how it's pulled, and about the choice to bring it back. You can start observing yourself in the context of interacting with social media. You can start noticing the feeling of wanting to reach for your phone or, engage in social media, and experiment with that. It starts with curiosity and kind of observation, which then that awareness can create some behavioral choices for a person.
Thank you. Okay, Sophia, does OCD come into play with these syndromes at all? Or could it be an offshoot of one of the other syndromes?
So absolutely. So, I focused on the three kind of syndromes that we were chatting about tonight, but you bring in any other psychiatric illness or syndrome that people experience, OCD, psychosis, bipolar illness, and you will see the fancy medical term is comorbidity, but the plain English term is, co-occurrence with any of these other syndromes we've been talking about. And again, there seem to be some that particularly co-occur a little bit more frequently. And I should toss the ball to Jed here because OCD and autism features can often be seen in children in co-occurring. I don't know if you want to comment on that specifically.
Yeah, I mean, the symptom domains or what manifests are in kids with autism that seem to look very similar to kids with OCD are rigid adherence to routines and insistence on sameness types of behaviors that can manifest that look very similar to obsessions and compulsions. In very young kids, we study these, we call them just right behaviors. It's important for young, even typically developing kids to have some routines when you're brushing your teeth or something like that. So these are domains that likely are, I think of these as a feature or a trait that is continuously distributed in the population. So you think about like height or weight, we see these features that are continuously distributed in the population, and they're going to be appearing in aspects of anxiety, general anxiety or OCD. Also autism, and we even see some of these kind of insistence on sameness behaviors in some young kids with ADHD as well. Really good question.
Great, thank you. Lydia, could you speak a little bit about developmental trauma and the hypervigilance that comes with past trauma versus teasing that apart from ADHD?
Yeah, that's a really good question. There's a lot of overlap with trauma and ADHD and it's a diagnostic challenge in childhood. We know that children that have been exposed to more trauma are more likely to have attentional issues and be diagnosed with ADHD. And if you really think about this, attention can be affected by so many things. A little bit like sleep can be affected by a lot of things. It could be that your bedroom is noisy. It could be that you're having pain. It may be that you have a sleep disorder like sleep apnea. Same thing with attention. And so having other conditions, whether it is trauma or anxiety or depression, can affect attention and can be sometimes challenging to tease out what's driving what. And with trauma, particularly with, as you mentioned, the hypervigilance, you will be, cueing to different things, maybe more frequently than somebody else. You may have more difficulty relaxing on average, and that can affect your ability to focus and to be, to be less, there's an interaction, not just with trauma, but with stress and cognitive ability and ability to focus. It's a challenge to tease out. And at the same time, we also have some literature showing that PTSD or post-traumatic stress disorder is more common in those who have history of ADHD. So those are studies with veterans. Which kind of point to the fact that ADHD may be a vulnerability factor in how you process stressful events. and how you can regulate difficult experiences. I think in some cases, the trauma is maybe the main thing that's driving the attentional issues. In some cases, there's truly ADHD history, and then layered with trauma, there's a co-occurrence of trauma-related symptoms.
Thank you. Jed, I'm going to give you kind of two questions at once. One is kind of a question about just the etiology of autism. Is it nature, nurture kind of question, like genetic causes versus environment? And the second question I'm going to pose at the same time is about, are there people, there's been kind of reports about like certain groups of people might have a higher prevalence of autism, or certain regions of the world. And so I guess, is that true that that some groups of people have higher rates of autism, and is that it maybe relatedly having to do with this causality question?
Yeah, these are really important issues to cover. So I think that the best evidence to date suggests that about 25% of cases of individuals diagnosed with autism, and that autism can be attributable to a single gene mutation. So we know we can identify this rare or rare mutation, and I think that that number may go up to 30% or something like that. But then that's gonna be what we know about these single gene type of explanations, genetic explanations. So 25, then about 74% is probably due to common gene variants. Sophia mentioned that depression is about 50% heritable. Autism is the most highly heritable of all the conditions that we've talked about, at about 80%. So if you are an individual with autism and you have an identical twin, there's about an 80% chance that co-twin will also have autism. So we know that genetics are very important, and they play a very large role. Now, if you were paying attention to the math, I left about 1%. There might be about 1% of cases that might be due to environmental factors. I mentioned one, the use of very specific anti-seizure medication during pregnancy, valproate, that we know does increase risk for autism. And there may be other features in the environment that exert a very small influence as well. What we do know is that variation in parenting, that proximal family environment, does not cause autism. There's no evidence to suggest that the proximal family environment or parent variability in parenting actually plays any causal role in the expression of autism. So when we talk about the environment, yeah, there may be a very small proportion of cases that we can attribute to something in the environment. The question about regional variability, I know that there was a question about the Somali population, and in the Q&A, I can real quick, and then I'll go to the kind of broader regional variability. But I think that the evidence that I'm aware of suggests that the kids in Minneapolis, Somali kids are showing similar prevalence rates to white Caucasian or white non-Hispanic kids. But what was anomalous was that a very high proportion of them also had co-occurring intellectual and developmental disability. And the way that I explain that is I think that it's too early to know whether that's a real finding. We're dealing with very small numbers of kids, and I worry that there's some kind of a selection effect, that we've managed to identify the small number of kids in the Somali community who had autism and a co-occurring intellectual and developmental disability. So I'm really worried about kind of the numbers that generated those estimates. And I'm also worried about the cultural applicability of our cognitive testing that we do, and how we don't do a great job taking into consideration cultural variability in many. I shouldn't speak for my other colleagues, but certainly in the autism world, we're relying on clinicians and their cultural humility and understanding to actually account for variability that is likely real in how these behaviors manifest. The data that I'm aware of does not suggest meaningful regional variability and prevalence across the globe. And I think that the kind of epidemiologists that I run with would suggest that if there do look like differences in prevalence estimates, it's probably due to differences in, inadequate sampling and methodology limitations.
Jed, that was phenomenal. Thank you for fielding my 2 question in one. That was really, really helpful. Sophia or Lydia, do you have anything to add to just what Jed was saying about cultural responses and tailoring?
Here.
Yes, I think there's quite a bit of understanding that, especially in communities of color, ADHD is both underdiagnosed and overdiagnosed. There's also less help seeking, and what we often see is more severe cases by the time they come to treatment. So those are the more kind of cultural things that you see, but when it comes to testing, of course, and neuropsychological testing is still quite a bit utilized in assessment of ADHD. There may be cultural limitations as well.
Wonderful. Thank you so much. Well, we're at 6:29, and so we won't have time to answer all of the questions, but I believe that we will have some opportunity to respond to questions afterwards. So stay tuned for that. And yes, thank you to all of our panelists for your time and sharing your insights into the complexities of mental health, focusing on the evolving challenges that individuals face as they transition from childhood to adulthood. And thanks so much to you, our participants out in the audience, for being here with us in the Mini Medical School today. And we hope to see you next week for the 3rd and final Mini Medical School session, which is The Aging Mind, where we'll be same time next Wednesday. We're going to have an amazing group of experts who are going to discuss the impact of aging on cognitive health and who are going to delve into strategies for promoting mental resilience. Thank you.